June, nearly July, and in a classic fashion of all the things that happen in OB and GYN worlds, chaos ensues, right? And that's okay because that's how we respond. Feels appropriate for the topic we're going to have today. But we're all glad you're here. We're having some technical issues with Zoom today. Hang in there with us. As usual, it's recorded, and the slide deck will be sent out soon. So you didn't miss anything if you joined a little bit late. We are just getting going this morning. So, as a gentle reminder, please put your name and your hospital agency group in the chat so we can make sure we take attendance like little kindergartners that we are. I'm in a new office this morning, and if I sound loud or echoey, I apologize. Next slide, please.
Sorry, Tara.
It's okay. So I don't know if you all are seeing, there's a large black box in the middle of, yep, everybody's seeing the same thing, Jill. Do you see that on your side? There's a lot, there you go. And there's another one at the bottom of the slide. Another black, like long box.
Oh, I do not see that at all.
Okay, we're gonna go with it. Oh,
So let me
okay.
reshare. We'll try resharing. See if
Sounds
that
great.
does.
I feel good about it, Jill. Feel real good about it. Do it.
Is it better?
Yes, yes.
Okay.
Who said we can't do hard things? All right, guys. Actually, can you go back a slide, Jill, or is this the? Yep. Okay, you're right. Go forward. So the next couple slides are just what we like to call rapid response, and just an update from either state work or national work. I would be remiss if I didn't say there's a lot happening in public health right now, both with funding, but also with news, information, some legitimate, some not. Social media is blowing up with lots of things that are in the patient world a little spun up. So we're trying to stay on top of that while also keeping our very important severe hypertension AIM bundle work moving forward. To the hospitals across the state who are doing important work during what we call our busy baby season, we see you. We also see that vacations are happening because we've taken them, and understand that that creates an interesting staff dynamic of a summer month. So we get all of that, and applaud the work you're doing to continue to keep patient health as a primary focus. When we talk about sharing resources, and I do know that the text on this slide is very small, I'm just showing it to you because I want you to know what's coming. In the next few weeks, champions and your OB lead providers will receive two different emails. We want to hear from you all what you would like from us. And the next slide will tell you more about that. But also, we want to share out important articles, important documents related to this bundle so that your providers, your staff have quick links and access to the most important protocols, data, the whys. So if you'll see on this list that we have started to create, these are the articles that we have, and quite frankly, we use as the most important articles related to the AIM bundle. They include everything from state-related data in Kansas to the national AIM articles and links connected to our safety bundle regarding hypertensive disease of pregnancy. So again, if you look through there, intimate partner violence is included. That's one of the topics today. But each of the projects, each of the important pieces of this bundle will be included in this link, or excuse me, in this list that you'll be sent. Champions, you will get this as well. Your OB lead providers will be getting it. And we really encourage a big share out of all of these things because I think that it's pretty important information. More information to come, but at least you've seen it so you don't go, what the heck is all of this? We want to make sure you had that data at your fingertips. Next slide. So where are we and why is this next piece important for us to continue to walk through protocols and begin to identify, again, data, but what do we do next, right? What are the important boots on the ground pieces? We're moving from quarter two of 2025 into quarters three and four of 2025, where we move from post-birth education, embedding that in our new hospitals that don't already do post-birth, sustainability in the hospitals that do, and sharing with our non-birthing facilities the post-birth education, ED treatment guidelines, all of the pieces that are outside of the OB specific units to make sure we're all on the same page, all the education is completed for hypertensive disorders, and moving into what you see listed there under quarters 3 and 4. What happens if you have the correct diagnosis, the correct treatment, and furthermore, the immediate treatment of hypertensive disorders requiring treatment needs to be enacted? Again, it's one thing to educate, it's the next thing to identify, diagnose, and treat. This is where we're moving to. So, again, protocols and reviewing protocols. Carrie's been working feverishly on connecting with many of you to review your protocols. We ask all of the champions who have not completed that step to have your protocols updated or reviewed by our team. That would be Carrie and I. To make sure that you get that sent in. Again, you've got to the rest of the year, but we want to start completing that task so that we've reviewed your protocol or helped you develop an updated protocol or a new protocol, centering around the identification and treatment of hypertensive disorders in pregnancy. You're also going to hear us start talking about OB simulations and some other really exciting things that are coming forward. We believe in Kansas that we will continue the work to move forward while also going back to pick up gaps. And post-birth information, for example, will continue to come out in terms of resources that can be used, in terms of how to keep it sustainable in your facility, how protocols are developed. We've got a lot of questions regarding emergency departments and the QI surrounding OB-specific outcomes. We're working feverishly on making sure everybody has the latest data. So as we move forward, hear us say that we're paying attention to the pieces that continue to develop. And do not hesitate to reach out if you're stuck or if you have a question about those as we progress. Next slide. So we talked about this already. Again, what are the challenges and the successes that we're experiencing? We certainly have some examples here in a second of the next steps and how that's working. But at the same time, I want to say to you, we understand that developing a new protocol is a big lift. Reviewing and having everybody agree on an updated protocol is also a big lift. But the data is pretty clear, which is why we provided the articles to your staff on what the protocols need to include and I would say the gray zone of how you can make those fit your facility and the needs at your facility. But again, happy to jump on a direct TA phone call or virtual meeting with anybody that needs that. Happy to do so. We talked about the fact that post-birth will be ongoing in terms of resources, but staff education and the embedding that education for staff, but also, of course, for every patient discharged from your facility needs to be started, if not already done, meaning happening. And then a quick update on the CUF project. We're working as fast as we can to get funding and decisions about exactly where we're going to pilot the CUF project to begin this exciting process in Kansas. The goal is to improve identification of hypertension in your patients, and how we do so is not, we don't need to reinvent the wheel, but how we help with funding and protocols and data extrapolation is important to us. So stay tuned. We will start with a small cohort in Kansas and then begin to spread out. And our hope is that by the end of the bundle, everybody, every county, every hospital that wants to use the CUF project is able to do so somehow. And then data update. Michelle Black will provide a data update in just a minute for us. Let's go to the next slide first, though. This is the menu item I spoke about earlier. So for champions specifically, if you're a champion for your facility, you're going to get a survey. And on the survey, if you're birthing and if you're non-birthing, we want to make sure that, number one, we can share protocols. Right now we're talking about hypertensive protocols, but we certainly want to share other protocols if those are helpful, or if you need one, want to share one. We're the epicenter, so we're happy to do that. But we also want to hear, we suspect that there are many of you that need the same or are interested in the same information or sharing. And so we're creating a survey that says, hey, tell us what you need, for example, for the OB ED readiness. There is a specific bundle kit for that we can help with. Where are you in EMS transfers? Talk to us about your maternal mental health at your facility and what is it that we can do to help. So you'll be getting a survey soon. what are the needs that you have at your facility? You can click as many of those as you need, and we will be coming back to you with very specific help and TA from our partners that are listed there. So, in other words, the warm handoff, if you're a breastfeeding friendly or baby friendly hospital, but you're struggling with a certain piece of that, again, great. We've got resources for that, right? So, expect this survey. Please let us help you. Please let us connect you to others that have the same questions, or we may find you a champion that can help others. We have a lot of that in our KPQC group, and we will improve all outcomes across the state easier that way. Next slide. I put these on here as a reminder to myself to say one of the menu pieces that I think is extremely important is when folks share um, toolkits or tools or resources across the state. The bottom right, you may remember Carrie Smith talking about these at our in-person, and then again, I think last month, but the badge buddies, right? So quick identification, what's the treatment, what are the protocols? If you would like copies of these badge buddies, we'd like to share them. Again, that'll be on the menu. If you would like the EMS transfer protocols, if you would, again, I'm just giving you pictorial examples of what we have at our disposal. And instead of sending out every single thing in massive emails, we really want to know from you. If there's something listed on the menu that you, or if there's something that's not listed that you would like, or you'd like to share out, we would love that. So again, free input and outtake, so to speak, so that we can make sure that everybody has what they need. Next slide. So today is about the maternal mental health piece and making sure that we talk a little bit about, I'm hesitating because I want to say the right thing. Maternal mental health in Kansas is by far the biggest red flag that we have. So while we talk about severe hypertensive disorder in pregnancy, and it deserves our attention, maternal mental health in the pregnancy, delivery, and postpartum setting is by far the biggest concern that we have in Kansas, and we want to continue to work on it. I want to make sure everybody knows that we're not collecting the national AIM data surrounding maternal mental health for this bundle, but we are directionally encouraging updated protocols, education of staff, patients, community resource vetting, etc. And so part of today is focused on that as well. I will also tell you that you get the resources in the AIM bundle even if we don't use data. So what the snapshot there that you see is that there are specific resources, national resources that are also available to you to help with things like patient debriefs and connection to community resources and educating staff about the trauma response that happens specifically around hypertensive disorders and the sequelae. Again, happy to share those out. Some really great information there, but we have great state resources and they're going to introduce themselves here in just a minute. Next slide. Sorry, just went over that. The communities for positive clinical outcomes, and I think the next slide. Can you show me the next slide, Joe? Yeah. So the slide before and this slide are really just, again, showing you where two things continue from fourth trimester initiative and how we're getting better and better in Kansas about making connections. We talk about the education and being aware of maternal mental health, substance abuse disorder, perinatal mood disorder, intimate partner violence, and all of these important words that we use to identify a need and multiple needs in some cases of our patients. As you remember from fourth trimester, we included intimate partner violence as a key bundle item. Again, we're continuing that work in the severe hypertensive disorder. Go one more slide back, please. Other way. Thanks, Jill. The perinatal person, and I think I'm preaching to the choir, but just let me preach for a second. The perinatal person must be looked at not just for her severe hypertension or her twin gestation or her race or her G's and P's. This is all of the people and all of the things surrounding her that are helpful, but she comes to us with just as many circles of needs, individualized and sometimes pretty large. This graphic to me is the best, most updated in Kansas to describe all the ways that we can jump back in with all of her needs and her circles, with our own circles and ways to help. Now go to forward, Jill. Awesome. Again, this is the data that you all have seen. Mental health conditions is listed third there. Um, we all know that sometimes there is a tie-in, for example, to the motor vehicle accidents related to mental health. We know that cardiovascular conditions, including our hypertensive disorders and pregnancy, create sometimes some maternal mental health conditions because of the brevity of the situation or the change of income or all the things that can come with the importance of treating, sometimes preterm birth, right? So we know that those things are tied together. So when we see them separated out in our data, also know that we're watching in Kansas for the tie-ins of those things. You know this because you see these patients. Next slide. So, Alexis, I am going to have you queued up here, and your slides may be out of order. Blame me for that part. I slid this in here, but I know you have more specifics for us. Alexis, can you go ahead and introduce yourself and tell us how you tie into all this that we're talking about today?
Yeah, absolutely. So my name's Alexis Tibbetts. I am with Kansas Connecting Communities. So we are the statewide perinatal psychiatric access program for the state. So we are provider facing. We work with providers to provide training, TA, just any support that providers need when working with a patient that is in the perinatal period. So specifically around mental health concerns. And we have partnered with PSI Kansas to let you guys know about this scholarship opportunity for additional training. So I meant to update my slide about the amount of funding. I believe that has changed since we've done some promotion of the scholarships. But there is a lot of different training opportunities available for people to get some additional training around psychiatric medication. Um, I have some specific slides. I don't know if you're going to share those later, Tara, that we can go into what some of those training opportunities look like. But yeah, there's a lot of different cool things to check out. And I think I see some familiar names on the call. So yes, and I see that question in the chat. Yes, anyone that works with a perinatal patient, the perinatal population would count as a provider. So you would be eligible to apply for that scholarship. So, and we have this resource, PSI Kansas. Their email is listed there if you have any questions about that scholarship opportunity. So they're happy to help and respond there. So I'm happy to share more with those slides later.
Clicking buttons and nothing's happening. I'm sure that's never happened to anybody else. Um, Lots of you have been working directly with Michelle Black. When we talk about dissecting data, submitting data, and how in the world we're going to do this for this bundle. Again, I'm going to tie all this in by telling you that we want to provide process improvement data for our bundle, but we're also watching it, we'll call it live in Kansas, so that we can actively help, let's say, a hospital that's at a 1 on some important criteria move to a 3 and then to a 5. And again, we know that there are lots of dynamics happening with each patient. And so it all ties into getting data and then how we can help. For example, what Alexis just talked about is one of the markers. Michelle, thank you for all your help with data. You want to walk them through the next couple of slides and where we are and what we can do next?
Sure. Well, I just did some quick slides. It's a broad overview, and what we are looking at is not patient information, but more facility entering information. And so this is how many facilities that entered information. And as I am still learning, I learned that 15 out of the 38 facilities that entered, that's 15 facilities that had a patient with an SMM episode. And so we do not have a large percentage of patients in Kansas. So this does align with how many we see in Kansas. So what we're looking at is that 39% of the facilities that are participating in the AIM bundle did have a patient with SMM. Next slide, please. So facilities who entered specifically about severe hypertension. So this is, I'm also trying to help people on this call, facilities, connect the data set. So this was the data question that was specific to severe hypertension. And this is one of the outcome measures. So we will only answer this question once a year. But again, it was 27 out of our 38 participating facilities had a patient with severe hypertension. So, and I just noted in the 11 out of 38 who did not enter, we don't know if 0 meant that data was missing, they weren't able to pull it, or they didn't know it, or if they had 0 patients, but it is listed that way. So next slide. Here we are just looking at, I'm trying to show how information was disaggregated. And I just want to show that if you were not able to disaggregate in the baseline data, you weren't alone. And so as we are moving forward and with the potential of being able to provide TA support, with the potential of being able to connect like facilities, that we are hopeful that we want to make this process easier for you and less time consuming. So I just wanted to show how many of the facilities were able to disaggregate. And on this specific set, the all 01, we had 15 facilities provide information, and out of those 15, 14 of them were able to disaggregate by race. So next slide. This one, we are just specifically looking at patients who had the preeclampsia, eclampsia, and HELP syndrome. So again, out of the 38 facilities, we had 27 of the facilities that entered data. And out of those 27 that entered, 15 of them were able to disaggregate. Next slide. So here we are looking specifically at our structure measures, and I'm gonna show you 3 of them, I believe. And I just want to show you where we are as a group in the process. So out of the 38 facilities, 30 of the facilities have already completed their post-birth process. Now, one of the benefits of being enrolled in both the 4th trimester and then moving into the severe hypertension bundle, if you had completed post-birth in the 4th trimester initiative, you are already fully implemented for this training. And this is a question that won't have to be answered over and over. So once you are fully implemented, that question will not be asked of you again, because we know that you've already met that criteria. So, and I do know that the 2 that are just started are 2 facilities that are new to the bundle, and they are in the process. Now, keep in mind, this is baseline data from 2024, so it is possible that those 8 facilities that were in progress and started, they may have already done the training in the first 6 months of 2025, but we are looking at data from 24. So next slide, please. This one is specific to asking if a person has been or is currently pregnant or has been in the last year. And so it is the same if you met the criteria in the 4th trimester initiative, then it rolled over. And we also, again, it is 24 data, so it's possible you've already fully implemented and it's just not reflected yet. Next slide, please. And I just want to make a special note on this structure measure. This is our policy and procedures. And we did have facilities that had listed that they were fully implemented, but with the stance that our team, Tara and Jill, need to review those policies and procedures to make sure that they align and have the criteria that is expected from the AIM data center. We indicated that it was in process, and after those policies and procedures have been provided to Jill and Tara for review, and they have signed off to acknowledge they meet that criteria, then you will be moved to fully implemented. So next slide, please. I was going to say that's all of my slides. So I will take questions at the end of the webinar learning forum if there are any other questions, but that is what I have for today.
Michelle, I'm going to change a name that you just used, but we're on the right track. So Carrie and I are actually the ones that are reviewing the protocols, the severe hypertension protocols. So if you are ready to submit these to Carrie, it's okay. You're doing all the right things, Michelle. If you're ready to submit those, you believe you're a 5, no big deal. Just email Carrie and I together or separate. We'll review those, give you feedback, and I would guess that a tremendous amount of you are in fact fully embedded in implementing protocols that meet the national AIM criteria. So look forward to seeing those. So transitioning back to, okay, here's where we are. Here's where we are on the bundle. Here's where we are on data. But hey, don't forget about the important piece of maternal mental health in the middle of that. Many of you who have been with KPQC for several years have heard of the Kansas Connecting Communities team. The MAVIS team and what MAVIS is and how all these things connect. I'm going to let the folks that are on the call do a better job than I do of connecting. But to me, the KCC team, MAVIS, all of the offshoots of that, our substance abuse team, our perinatal consult line, this team is underutilized in our state for one of the things we just talked about, which is the massive, important moment of eye-to-eye contact, phone triage, or helping families find help in that moment. And as I transition to introducing these folks, I wanted to make these four bullet points very clear. We are about checklists and algorithms in our team, and in the state and national work. But please hear me say, and please hear it echoed from the MAVIS team, from the KCC team, when we talk about intimate partner violence, when we talk about substance abuse disorder, when we talk about the tie-in of how the medical conditions overlap. The patient is the focus, not the checklist. And I think we need to start talking to our teams at the local level about that. Making connections for patients is our goal. Making connections for patients with intimate partner violence is our goal. The story about trauma at birth, right? So that the birth becomes the heavy lift, the debrief, and the importance of the mental health referral post-discharge. I'm thinking about our preeclampsia and our eclampsia patients, and the sequelae that we forget post-discharge that happens for them can't be forgotten, and the importance of this team in that moment. And all partners have to be in. And I said this, I'll say it again, from the phone to bedside to anyone who comes in contact with any of our patients, they need to be educated and they need resources. Next slide. And here is the slide that I knew Alexis was coming. So you've already done a great job introducing yourself. You have a great resume, my friend. But here's your slide, Alexis. So let's give them the information. Let's get everybody connected so that we can do better in Kansas.
Yeah, hi. So I am with the Kansas Connecting Communities team. I am the sub-project lead of our TA service. I went to KU and got a degree in psychology, and I currently work for the KU Center for Public Partnerships and Research with the Kansas Connecting Communities team. And so I've worked with several of you on TA. So I know we've met and gone over screening implementation particularly, and how to develop a workflow for screening, what the best screening practices are, how to refer for screening, like after you get a positive screen for mental health, and some of those things. So we can go to the next slide. And you can go to the next slide there. Thank you. So Kansas Connecting Communities, we are funded by HRSA, and we are administered through KDHE. And these are some of our partners. We have providers through KU Med. And like I said, I'm with KU CPPR. That's where our team is based out of. And then we have different trainers that work out of like CKF addiction treatment. And then, like I said, we partner with PSI Kansas and the Kansas Maternal and Child Health organization as well. And we can go to the next slide. So a little bit more about Kansas Connecting Communities. Like I said, we are the statewide perinatal psychiatric access program. We are aiming to improve maternal and child health outcomes across the state by building provider capacity to both identify perinatal mental health and substance use disorders and intervene through evidence-based treatment and referrals. And so often that begins with screening and then knowing what to do after that screening through either treatment or referral. And then we are building capacity by providing consultation, referral support, training, and technical assistance. And so you can go to the next slide. A lot of our services are based out of our consultation and resource network. That is the combination of us, our program, KCC, and Kansas Kids Map, which is the pediatric mental health consultation line. So you have one phone number and you can call and have access to 2 programs. That's really great for people working with both populations. So you're able to have access to support with both programs. You can go ahead to the next slide there. And with the consultation line, you're also able to, if you're managing medications for a patient during the perinatal period and you have questions, we have a perinatal psychiatrist, Dr. Biter. We also have an OBGYN at KU Med, Dr. Tara Chediar, and they staff the consultation line. They're able to answer those questions for you and help with resources and referral support as well. So the reason I'm here to talk to you guys today is about those training scholarships. So through PSI Kansas, we have several trainings available and lots of scholarship money available to fund those trainings. Like I said, you can reach out to PSI Kansas directly if you have questions. I've personally done some trainings with them. I believe I did advanced psychotherapy training and it was fully on Zoom, self-paced. They also have live trainings available and it's all around perinatal mental health specifically. So there is, sorry, my cat apparently wants to join the meeting. And so you can follow that QR code to take you to the application for 2025. And within the application is actually the embedded link for the list of trainings that are approved. And then I believe the frequently asked questions as well. You can go ahead to the next slide. This is just more about the PSI trainings. The application is really short and you hear back within like a week. So it's well worth your time. They fully fund your training. Some of them you do have to pay out of pocket and then they'll reimburse you later and it'll say within the chart if that's the case, so you know up front. But otherwise, the scholarship pays for the training directly, so you don't have to worry about that. And then, like I said, there are a variety of training topics available. So there's psychotherapy, trainings around perinatal trauma, infertility, psychopharmacology, and then there's different levels to some of these trainings. So if you've completed one, there might be additional training beyond that. And there's also some of the initial trainings if you're newer to maternal mental health or perinatal mental health, they have some intro classes to those that you can take. So I can also drop the email in the chat for PSI Kansas. So you have that a little easier to access. If you have any questions, you can reach out to them directly. I'm also here to answer any questions that I'm able to answer today. Another benefit of these training opportunities is that if you are working towards receiving your perinatal mental health certification, a lot of these trainings will go towards that. And so that's a really cool opportunity. That is something that you can receive through PSI Kansas. So there's more information on their website about that as well, if you have questions about that. Like I said, I believe they have distributed a lot of the scholarships this grant year already. So if they are, if it's not able to receive the scholarship this grant year, you would be put on a wait list and receive it in October. So there's still plenty of opportunities to receive scholarship funding within the coming months. You would just be put on a wait list and it's first come, first serve. So if you have completed a PSI scholarship or training previously and you're interested in doing another, please apply again. There's no limit to how many you can do. So they're really wanting people to take advantage of this opportunity and to get all of the training that you can. So it's just really exciting to be able to do this. You can go ahead to the next slide.
Alexis, I also want to jump in.
Yeah.
These resources and these connections will also be, for those of you that we just talked about, the OB providers will be provided the links and the connections to that too. So everything you're seeing will be coming out in your slide deck, but you'll also get it in a follow-up email for those of you that are interested in the training for sure.
Amazing. Thank you. And then I just included this as well, that through our program KCC, we also offer a lot of free trainings, either virtually or in person by request. So these are some of the things we cover. Like I mentioned earlier, we talk about screening recommendations and best practices. We do kind of a maternal mental health 101 covering perinatal mental health conditions and some of the basics about prevalence, risk factors, symptoms. We can do more of a deep dive in perinatal psychopharmacology with our psychiatrist, Dr. Biter. We can talk about policy as well as care billing and reimbursement. And then we can talk specifically around perinatal substance use identification and intervention. So there's always the option to call our consultation line if you have questions or if you were wondering which training or technical assistance option would be best for your organization. And that is our information there. You can go to the next slide. And then that is our QR code to sign up for our program if you're interested. If you're not already signed up, you can get access, early access to trainings in the PSI scholarships. So I think that scholarship funding goes kind of quick sometimes. People are really excited to take advantage of those trainings. So we send out that information really early as soon as we know about it. So if you're not already signed up for our listserv, I believe you can sign up for that via that QR code as well. We have a lot of opportunities to earn CEs. And then again, you would also receive access to any information between KCC and the Kansas Kids MAP programs and have streamlined use of those networks as well. You can go to the next slide. And then if anyone has any questions now, I'm happy to answer those. Otherwise, I can take those at the end.
Yep, if that's
We'll do
okay,
those at the end.
Alexis. Yep, would that be
Okay.
okay? I want Hannah
Awesome,
to
yeah.
get a chance here. We started late, so I apologize to everybody.
So
That's on
sorry.
us. Next slide, Hannah, I think this is your cue, my friend.
Okay, well, hello everyone. I see many familiar names and faces on the call today, but my name is Hannah Figs Horde, and I am with the Kansas Coalition Against Sexual and Domestic Violence. And we are a part of the Mavis Project as well as KCC. And so really what we do for folks and what the Mavis Project is all about is really increasing collaboration between our perinatal healthcare providers, our mental health care providers, our intimate partners, service providers, local across the state that are in each of your communities in order to reduce homicide and suicide during pregnancy. And as Alexis mentioned and Tara mentioned as well, mental health is a huge red flag. for perinatal, all kinds of perinatal health, but also for intimate partner violence during pregnancy. And so really here's my contact information. We're currently hiring for a new maternal anti-violence innovation and sharing project coordinator. But we have training and technical assistance opportunities available around not just, best practice in addressing intimate partner violence in your setting, but we can also help you look at your policies and your practices and your procedures. I wish there was a cookie cutter best for every site that I could just hand you all of the answers. But every site and every community is different, especially now that there are folks on the call who are, OB settings and non-birth settings. Sometimes we need to dive into what's going to be best for your site specifically. And so we do offer TA and training by request. I'm not sure how much time we have, but we can go to the next slide.
Hannah, I was just talking to Jill on that about that on the side.
Okay.
Why don't you hit the high points are important and we'll let people fall off at one that
Yeah.
need to. And if you'll continue, we'll record it and then share it out. That'd be okay?
Okay, well, if we could just skip a couple slides, I'll get to some good stuff. This is educational and not legal advice. Go ahead and skip this as well, Jill. Really, anytime we talk about intimate partner violence, even though nothing I'm going to talk about today is intended to be triggering or upsetting, I know there are folks on this call who have experienced intimate partner violence themselves. I know there are folks on this call who've struggled with their mental health and maybe feelings around suicidality. And so please take care of yourselves. The statewide hotline for folks who do need support around family violence, intimate partner violence, domestic violence is here on the screen, and they can help get you connected to resources. So I just want to say that if you need to step away, take care of yourselves first. Next slide, please. Really, this is what I was talking about earlier. Down at the bottom, you can see the different members of the Maternal Anti-Violence Innovation and Sharing Project. The Kansas Coalition, we are one piece of the puzzle. We know that these issues are interwoven and interconnected. And the MAVIS project was the Kansas Maternal Mortality Review Committee's idea and next push in order to impact these intersectional deaths from folks who are experiencing multiple different social determinants of health. Go to the next slide. Really, this QR code here is going to be really important for folks on the call, especially if you've never seen me present before. This is where you can find the contact information for the local domestic and sexual violence service provider in your area. And so, one of the main things that we train on in the training that I provide is around best practice, which includes being collaborative and in touch with your local service provider so that you can make those warm handoffs that Tara was mentioning earlier. When you know who in your community you can call when someone needs help, patients are more likely to utilize that help. So let's go to the next slide. So our member programs across the state, they are really who you think of when you think about domestic violence services. And here at the coalition, we're the statewide nonprofit, so we accredit all 25 of those member programs. We do public policy advocacy. We develop resources for different topics and different professionals. And really, our goal is to provide that statewide best practice technical assistance for folks. Next slide, please. And our member programs, those are the folks that you think of. Those are the folks in your own communities and your own counties that provide shelter services, court advocacy. They help survivors in your communities navigate their options, whether that is coming into shelter, whether that's safety planning, whether it's, making a safer plan to stay because there's limited resources in some of our counties. Those are the folks that you think of, and those are the folks that really are going to be your partner in addressing intimate partner violence in your communities. Next slide, please. Really, it's important to know intimate partner violence and domestic violence. They are often used interchangeably, but the important thing is that both are a pattern of behaviors that is used intentionally in order to gain and maintain power and control over another person. And oftentimes folks, we think of it almost like a mental health issue. And it's really important to acknowledge that these issues are a pattern. It's not a one-time situation. It's a pattern of power and control. So next slide. And I think for most folks, this makes sense. There are a lot of health impacts of intimate partner violence. So we think about the physical impacts, injuries, traumatic brain injuries, strangulation, but then we don't always think about some of the reproductive impacts and outcomes of intimate partner violence, which is oftentimes unintended pregnancies or rapid repeat pregnancies, those back-to-back pregnancies, STIs. And we also know that for folks who experience this kind of violence, they're more likely to develop cervical cancer, as well as a plethora of mood and anxiety disorders, substance misuse, suicidality, cardiovascular disease, including hypertension, and unfortunately death. So let's go to the next slide, please. And really, it's important to know that the data is fairly clear that in the 12 months before pregnancy, if you experience physical violence, then your pregnancy and your pregnancy outcomes are going to be more difficult. You know, I mentioned high blood pressure is a common denominator for folks who experience intimate partner violence, but also bleeding during pregnancy, nausea, vomiting, dehydration, again, that stress response on the body. Different infections, urinary tract infections, placental abruption, and fetal demise. Go to the next slide. We can go to the next slide. We touched on this stuff. Okay, so, you know, one thing that's really, really important for folks to know in healthcare settings, especially if you're working in a space where you might be with a patient for 10 hours, 12 hours, and you might not see them again, is that leaving a relationship really can't be your goal for the patient. It can be their goal for themselves, and you can help support them in that. But you know, our role is to really connect with them and to reduce their isolation and not try to convince them to leave if they do disclose violence or if we do suspect violence is occurring for them. So let's just keep that in mind. Next slide. So there's lots of reasons why it's hard for both providers and patients to talk about intimate partner violence. Most sites across Kansas, not all, are required to ask screening questions. You know, and I think the most common one that I hear is, do you feel safe in your home? But there are lots of reasons why patients have a hard time too talking about that. And you can look at that there and you'll have these slides. So we can go to the next slide. And really what the data shows that survivors want from their healthcare providers is they want to feel a sense of autonomy, and they want to be informed about the information, how the information that they share with their provider will be used and when it's confidential and when it isn't. They want to be validated without judgment, but most importantly, they want to know that their providers will be able to help them if they do make a disclosure, that they'll be able to refer them to someone in the community that is an expert, that they understand the impacts of violence on their health and their pregnancy, and that they understand that it's a really complicated issue. And again, that goes back to the validation without judgment. Next slide. And so what we know about screening, and there's 2 decades around of data around the limitations of screening alone. So if you are a site that is asking, do you feel safe in your home? You likely have experienced folks say, yes, I'm safe, and they move on, and you never really get disclosures. And, you know, in Kansas and across the country, really, those tools only capture between 1 and 11% of folks who experience violence, when we know that it's more like 1 in 3 women and 1 in 7 men experience some form of domestic violence. So those tools alone are not working. And so really what the intervention that we train on is all about is this question here. What if getting disclosure and identifying intimate partner violence was no longer the goal? For all healthcare providers, it's really your role and your perspective to dig deeper and to find the answers and to put the pieces together. And the intervention that we train on kind of takes the pressure off a little bit. It's not about you catching intimate partner violence. It's about you establishing a relationship in which your patients know that if they were to disclose to you, that they would get some support and they would get some help. So it takes the onus off of you, and it still gives patients access to all of the information that they need. Go to the next slide. And so this is an overview of what the training that we provide is all about, and what the Maternal Anti-Violence Innovation Sharing Project, what we have decided is the best tool for this. And so CUES is the acronym for the intervention that was developed specifically for healthcare providers and intimate partner violence. And it's an acronym there. You can see it stands for confidentiality, universal education, empowerment, and support. And really the key piece of this that we will go more in depth into later is that universal education piece. It's instead of relying on your disclosure screening question to make a referral or to give someone the contact information or to even bring in your own social worker. It's that every patient gets information on intimate partner violence and how those relationships impact your health, so that they can decide what is best for them and what resources they need to use. So let's just go ahead to the video, Jill, real quick. It's like 1 minute video. All right. This will just show you what this intervention is really quickly. Go for it.
One of the things we've started to do with all our patients is give them these safety cards. Even if they say their relationships are great, and even if they're not in a relationship.
Why?
Because we know that relationships change. And we also know that many women have friends and family who need help, but they don't know what to do. This card talks about what women do and do not deserve in relationships. And it has safety information and 24/7 hotlines on the back.
Thank you for these. My sister, she's been struggling a long time, and I keep trying to figure out ways to better help her.
I'm sorry to hear that about her.
Yeah, me too.
Well, I'm glad these are useful to you and possibly to her. You can call the numbers on the back for more information about how to help.
Thank you.
Do you have any questions?
No, thank you. These are perfect.
Great. Is it okay for me to ask my assistant to come back in so we can do your PAP?
Oh, yes, please. Please send her in. Yeah. Thank you.
Okay, great.
So the really important thing about this intervention is that everyone gets access to the information that they need to decide what they need to do with it without an expectation to make a disclosure. As you can see in that video, the beautiful thing about this is that it doesn't matter if those cards, she was feeling moved because those cards were for her, or if they were for her sister. She still got the information that she needs to keep herself safe. And so Jill, you can just skip ahead to my contact page, or we can just, yeah. So really the next steps, there's links here to recorded trainings on CUES that I've provided in the past. and you can register. They're also available for continuing education credits. They're 1 hour long, an introduction to cues and how to implement cues. And then there's an advanced version that really gets into more of some of the practical policy considerations. And, you know, like I mentioned earlier, one of the most important things is that you make a connection with your local member program, and I am available to help connect any of those pieces. There's a link here to order your own materials. You saw in the video, he used the safety cards. They're the size of a business card and they fold out, and they're really a tool for providers to do that universal education. And then finally, we're here at the Kansas Coalition to provide that policy support. We can talk about best practices, we can review your policies, we can provide sample tools and strategies and workflows and all of those kinds of tools that can help you in your sites best respond to folks who are experiencing violence. All right, I think that is it for that. Like I said, we're hiring for the maternal anti-violence innovation and sharing coordinator here at the coalition. I was in that role for the last 2 years, and so I am not walking away from it. So if anyone has any questions or needs any additional information, please reach out.
Hannah, Alexis, Michelle, you guys, and for all of you that joined us, I'm really, really, really thankful. Everybody has, it may feel a little disjointed today because we're giving you a lot of content in a very short space. On my part, it may seem disjointed, but in my head, this is so very connected to our bundle and very connected to the summer months. Speaking of that, we're going to give you July off. For those of you that need to go back to your regular scheduled programming, since we're after 1 o'clock, you're welcome to drop off. But for those of you that are on, again, expect a menu of choices to include the MAVIS information, to include the KCC information, to include anything we can do to help be helpful in Kansas right now. We want to see some follow-up on your protocols. We want to connect you to direct TA regarding the protocols, but also to these projects within our KPQC network. And what an impressive network it is. I think the word that you should take away from the day is connections. Connections to patients being the primary goal, being aware, watching, treating, gently being present. And I know you all do an amazing job at that. And now you're going to take that back to your sites and feel empowered, I hope, to encourage the project. By the project, I'm talking about the entire work that you do. Hannah and Alexis will expect to hear from you directly, but if you have questions about what to do next, reach out to Carrie or I. Michelle is going to keep watching the data. Thank goodness for Michelle, because that's how we know if we're making change in Kansas like we wanted to. With that, I'm going to stop. If there are questions for us, please stay on. If not, we will see you all in August for our next learning forum.
While we still have some participants here, I was just going to add that if you have change or updates in your data, you're welcome to email me directly.
So this is Tony Carter from Neosho Memorial. I do think, Tara, that I sent a copy of a draft severe hypertension protocol to you and Carrie. I just wanted to make sure. I think sometimes I think I did things and I didn't really do it.
Tony, you are not alone. And I bet if everybody was still on here, 99% of us feel the same on a daily
Thank you.
basis.
Okay.
Tony, you definitely did. What we're trying to do is consolidate our protocols and review them together. I really think Carrie is the best person to review
Okay.
them, since this is a higher level protocol person for the job. And so, yes, you did. And we will take a look at that.
Okay.
We are not deadlining you or us about getting those done, but we want to get those that you've sent in done as quickly as we can. So if you haven't heard back from us, give us through the 4th of July, would you?
Okay,
If you haven't
sure.
heard from us before that or after that, please call or email right away and we'll get you taken care of.
All of our timing of our committees that it has to go through I pushed it on through, and so I'm hoping it's
Great.
okay. If it's just minor changes we need to fix, it'll be fine, but
Great. Good job. I know what work that takes.
okay, thanks.
KFMC friends, do you want me to stop recording?
Yes, please. I was just messaging Brenda.
Perfect.